All right, next we're going to be talking about vascular disorders, so things after the heart that still impact the circulatory system and cardiac functioning. Two big ones we're going to talk about are abdominal aortic aneurysms, or AAAs, so AAA, and peripheral artery disease. The reason we're talking about these two things together is that even though the etiology of these problems is completely different, the effects of these problems on the body do line up in a way, and we'll elaborate on that as we go through the presentation. But they do tend, if you think about them the same way, it can help you to cluster the information and kind of make sense of them a little bit easier. So AAAs, or abdominal aortic aneurysms, what they are, we're talking about the part of the aorta from where it leaves the heart through the thorax. So above the brachial, or I'm sorry, the femoral split. So we're talking about what's going on in the body. And an aneurysm is really just like an enlargement of that vessel. So what happens is you can get all kinds of different presentations of abdominal aortic aneurysms, or aneurysms anywhere in the body. They can be saccular, they can be fusiform, you can have pseudoaneurysms. All of these are different types of aneurysms that can occur anywhere in the body. But when they occur in the abdominal area, then we really do get concerned. And the end result of all of these is that they're going to have an effect on blood flow distal to that aneurysm. So we do want to pay attention to that, and that's really where talking about AAAs and peripheral artery disease does line up a little bit. Because peripheral artery disease, we're talking about everything that's not the abdominal aorta. So everything below the femoral artery split. So these tend to happen in the legs, but can also happen in the arms. We're talking about everything not part of the trunk of the patient. So normally vasculature should be open like this, but with peripheral artery disease, we get narrowing or constriction of the peripheral arteries, either from plaques, inflammation, that sort of thing, or sclerosing, which is like scarring of the arterial wall. But for whatever reason, that artery becomes narrow, which impedes circulation downstream of wherever that constriction may be. And that's where the two really are similar. So our etiologies, this is where they are still completely different. The etiology of a AAA, one can be atherosclerotic. So as the lumen of the abdominal aorta narrows, it causes pressure upstream of where that narrowing is, which can lead to an aneurysm formation. Smoking, hypertension, smoking because like it's nursing school. Hypertension, especially uncontrolled hypertension, increases the pressure on the lumen of that abdominal aorta and can cause or exacerbate an aneurysm that may form. So hypertension, big one, that one should be in red. And hyperlipidemia, so very high levels of lipids in circulating volume, meaning that atherosclerosis is much more likely to happen. And trauma. So trauma is always our wild card. Patients with abdominal trauma or force against their aorta can present with a AAA. So thoracic aneurysms are the more rare of the two. Those are the ones above the level of the diaphragm. Only about 25% of cases are thoracic aneurysms. Abdominal aortic aneurysms make up the vast majority of the cases that we tend to see for our AAAs. So the AAA is the abdominal, TAA is our thoracic. But most of them do occur in the abdominal space, so below the level of the abdomen. For peripheral artery disease, we have some similar risk factors that we do for our AAAs. So atherosclerosis, I can barely say that word. There's like something physiologically wrong with my mouth that I can't get from there to there. I don't know. But yeah, it went all wrong. That one is the big cause for that narrowing of our peripheral artery lumens, impeding circulation. Smoking, because it's nursing school, and because it causes irritation to the vascular lining, can cause sclerosing of the vasculature. Hypertension, hyperlipidemia, so same as our AAAs. The other big one is advanced age. As patients lose vascular tone or have more difficulty maintaining vascular tone, that can cause narrowing of their peripheral arteries, causing impaired circulation. So this is what that tends to look like, is we see these areas where you can see that there's not great circulation in that area. There's a lot of inflammation, a lot of dry skin, a lot of very, very poor perfusion to the distal foot, unfortunately, on this individual with a very pinky purple toenail, which is covering up their foot fungus very poorly. So for AAA, our symptoms. AAAs suck because very rarely do patients have symptoms associated with these. Severe back pain can be one of them, but that's also very non-specific. And most of the time when patients present with back pain, we think they've got some kind of orthopedic injury, so not super helpful. But severe back pain can be part of that presentation. Diminished or absent pedal pulses can also be a big presentation. So because they have that impaired flow somewhere in the core of their body, everything downstream is going to be, they're going to have poor tissue perfusion downstream of wherever that aneurysm is that's impairing their normal circulatory flow. So if we see kind of this combination of patients with back pain, patients with this impaired pedal pulses or diminished or absent pedal pulses, vital signs immediately. Because the next thing we're looking for, hypertension. Especially if patients don't know they've had hypertension, that means it's uncontrolled. If they didn't know they had hypertension, they were definitely not doing anything to lower it. So we want to check for that immediately. And then renal failure. Renal failure because think about this anatomically, the aorta comes out of the heart, first branching to the brain. Usually it's close, there's very rarely an aneurysm kind of at the arch. It's always in the descending component. And we know that abdominally is where 75% of our cases are. So the next big branch is our renal arteries. So if we have impaired circulation to our renal arteries, then we're going to have renal failure for these patients. What's one of the best ways that we can detect renal failure in our patients? Best way is lab values, but that's not part of our scope of practice. So independent interventions that we can assess for renal failure, urine output. That is the big one for us as nurses to independently assess renal function in our patients. Your patient should produce a minimum of 30 mils of urine per hour. If they're making less than 30 milliliters of urine per hour, they are in renal failure. So that's one of those things we want to check. This would be a pre-renal etiology of renal failure, meaning the blood flow to the arteries is impaired, which is what's causing their renal failure. The kidneys are not adequately perfused because of the aneurysm upstream in the circulatory flow to where the kidneys are anatomically. For a peripheral artery disease, symptoms, very different presentation. You get this thing called intermittent claudication, which is kind of a fun thing to say. This is where muscles start to ache or they have pain in their skeletal muscles with exertion. So that activity demand of oxygenated, nutrient-rich blood, because they have a flow problem, as soon as they start to have activity, their cells start to become starved of nutrients. So they start to die, causing pain. So that's the claudication. And the reason it's intermittent is because it comes and goes with activity and with rest. So they have an onset with activity and a resolution with rest. That's the classic picture of intermittent claudication. And then that pain is reproducible when they start being active again. So that's kind of that big intermittent claudication presentation, which is really prevalent with our peripheral artery disease. Also a very, very poor CMS assessment. So CMS, circulation, motion, sensation. So cap refill is going to be garbage. Their motion, they're going to have peripheral weakness. So they may have really strong grips in their upper extremities, but if you ask them to move their feet, very weak pushes and pulls with their feet. And sensation, very, very poor sensation. So they may not be able to differentiate sharp versus dull sensation when you poke on their feet or their hands, or they may have neuropathy. Could be some other things. There also is this funny skin presentation where they have thin, shiny skin. And it looks very taut over their hands if they have any edema, or it's very wrinkly if they don't have any edema. So this, see how shiny all that is? It's hard to tell because of the camera, there's clearly a light on it. But all that shiny, thin skin, that is a classic presentation of peripheral artery disease. So for diagnosis for our AAAs, chest x-ray. We want to see it. That is a ginormous AAA. So there's the heart down here, lung, spine down the middle. That big bulge, wasn't born with that. Should definitely see a doctor about that one. That's jacked up. EKGs. So we want to check the electrical activity to make sure that whatever is going on there isn't causing a heart attack. Because one of the big presentations is going to be kind of generalized pain, weird stuff. So we want to rule out a heart attack as well. CT scan, again, so chest x-ray, we're going to visualize it. CT scan is a higher detail image of what's going on in the thorax. So we want to do that. And then aortic angiography. So we're going to inject some dye into the patients and visualize where exactly blood is going in the circulatory system. So we can see the aneurysm in its totality, not just the shape of it. For peripheral artery disease, diagnosis is very different. So palpation of peripheral pulses. Easy one, right? We can all do that independently. We do it on all our patients all the time anyway. For patients with peripheral artery disease, oftentimes our palpating their pedal pulses is really going to be garbage. We're not going to be able to do it very well. So we're going to need to use a Doppler, which is kind of that sound machine that we can use to assess their pedal pulses. So if you guys have never used a Doppler, YouTube Doppler pedal pulses, so you can hear what it sounds like. It sounds like a whooshing sound. Like you put that little wand on the same place that you would palpate their pedal pulse, and it goes whoosh, 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 whoosh. And that's the sound of that Doppler picking up their pulse. So first thing we do, palpate their pulses. We're probably not going to be able to, so we're going to have to Doppler them. Then we collect what's called an ABI. ABI is your ankle brachial index. It's like a blood pressure for their legs. So we put a cuff around kind of the bottom portion of their leg, and we collect a blood pressure using that Doppler on their pedal pulse. So that's really what an ABI is. We do it on both extremities, and we do some math to figure out whether they have a delta, which is a difference between their left and right. And then angiography, we want to visualize exactly where the constriction in their vasculature is, so we know everything downstream of wherever that constriction is, or the blockage, that's where they have impaired circulation. So for our nursing diagnoses, risk for impaired cardiac output is a big deal. Also, risk for impaired peripheral tissue perfusion are our big ones for our AAAs, right? Impaired tissue perfusion, also a big one for our peripheral artery disease. Another big one is risk for impaired skin integrity. If those patients have that very thin, shiny skin, it's also very fragile. So they're very high risk of developing some kind of tissue injury where they have an impaired circulation. So also a big one. Impaired distal circulation, something like that, is also a really good one. Just to really kind of diagnose that problem of tissue perfusion in the extremities. So our medical plan for a AAA, if it's unruptured, yay, that's the best thing, because a ruptured aorta, not good. Yeah, really not good. So unruptured, we're going to do an aneurysm repair, which is a stenting, grafting combination procedure. This is what the procedure looks like. So they cut open the aneurysm, put a stent in there to give it some structure again, and then they sew the natural aortic vasculature back over the stent. So it looks anatomically correct, but it's almost like they put a Chinese finger trap inside there to prevent it from having an aneurysm again. Also, they can do what's called a clip, which is if there's like this bulging kind of aneurysm like this, they'll put this little guy in there and it kind of clips it off so that there's no circulation into that bulge anymore. There's only normal circulation in their natural artery flow. A ruptured AAA, muy bad, like 90% dead bad. This is an emergency surgical issue. So they're going to use one of these clips to try and close wherever the rupture is. The big problem here is if you have a ruptured AAA, you're bleeding out into your abdominal cavity or your thoracic cavity, both of which, as we've learned, can hold quite a bit of blood before you start to have symptoms. So odds are you're going to present with hypovolemia first, but there's not going to be any trauma. It's not going to be obvious where they're bleeding. So we have to find the source, find where they're bleeding somewhere in their body. These are bad. These are really, really bad. Yeah. One of the other things we're looking for, did I put it up here? Ish. Back with your assessment. For AAAs, one of the other things we listen for as nurses, is a pulse, like a strong pulse below the level of the diaphragm, like in the abdomen. If you can hear and feel pulsation in the abdomen, that's also suspicious of a AAA. Okay, here we are. Okay, PAD, over here. So medication is a big one that we give for patients with PAD, with this narrowing of the vasculature in their peripheral arteries. One of the big medications we give is antiplatelets. The reason here is anytime there's a constriction like this, it causes turbulence in the circulation. Anytime there's turbulence in circulation, the body wants to coagulate. So we want to prevent those platelets from clumping together and prevent complete occlusion of that narrowing. So we don't want a blood clot to block that off completely, causing complete ischemia downstream of that narrowing. And then anticoagulation also prevents the complete occlusion. So this prevents the aggregation of the platelets. This is kind of the clotting cascade. We want to interrupt that. The other big one is supervised, underline that, exercise therapy. Seems odd because we know intermittent claudication is one of the symptoms of peripheral artery disease. That's why it has to be supervised. We do want to encourage activity and exercise in patients with this because it will improve secondary pathways of blood flow around where the occlusion or narrowing is in the body. So some of the other peripheral arteries that feed the same part of the extremity may actually become more, they may have more blood carrying capacity to perfuse those distal tissues around the vessel that is partially or fully occluded. The other thing then there's a couple other medical plans that may happen where we get into procedures that are done. One of them is venous stripping. This is like shaving down. They do an intravascular procedure and they shave down all of the substance that's occluding the peripheral artery to relieve flow. If they can't do venous stripping, they'll do a procedure called a FEMPOP bypass. FEMPOP bypass stands for femoral popliteal bypass, talking about the vasculature. So what they'll do is they'll take the femoral artery and femoral vein, take that vein tissue and make a bypass around the area that is closed off, and have that surgical procedure. That's why I put that little knife there, it's to remind me. It's that surgical procedure that bypasses the constriction or the occlusion to return normal blood flow distal to that abnormality. So that's one of the other procedures that can be done for peripheral artery disease. Our nursing plan, again, back to our AAAs, very, 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 very frequent assessment, especially for hypertension. Even after they've had intervention, we still need to make sure that their blood pressure is well monitored. Because while that surgical repair is healing, we don't want to jam a bunch of pressure on there and blow out the stitches internally. So vital signs, big, big deal, especially for that uncontrolled hypertension. And then our CMS checks, Again, like checking distally to where that aneurysm is to make sure that there's adequate blood flow downstream of where the physiologic problem is. And renal function monitoring, again, like we talked about for the diagnosis, the renal arteries need to be adequately perfused to prevent renal failure. So if we're making more than 30 mils of urine an hour, 2 thumbs way up, that liquid gold is good all day. So do that. And prep our patient for surgery. There's only surgical repair for an abdominal aortic aneurysm, so we want to prepare them for that procedure. Teaching for peripheral artery disease. So we want to make sure that they don't cause tissue damage related to occluding blood flow to their legs. That's the big thing. So a lot of this can be postural or dietary type teaching. So postural, avoid crossing their legs. Anything that's going to cause an impaired circulation, we want to teach them to avoid that. So sitting on hard surfaces for a prolonged period of time where they're occluding blood flow distally. Dietary teaching, also prevent like a low-fat, low-cholesterol diet so that we can prevent the accumulation of more sclerotic material into the arterial system. Also routine CMS checks, so the same for both. Because we want to make sure that we're not having any tissue necrosis downstream of where that occlusion is. We got to have normal circulatory function downstream of that physiologic abnormality. So things we want to do, AAA, this is an ICU patient. They're jacked up, like they're literally about to explode on the inside, which is not good. So these patients are very sick and we need to treat them as such. This means they are ICU material. They should be on stuff like this. Many things, many pumps, many monitors, hot mess. That is our AAA patient. Q1 hour assessments. The more concerned you are, the more symptomatic your patient is, dial up the assessments on those patients. So we really, really, really need to do those Q1 hour assessments on our AAA patients. For our peripheral artery disease patients, these are not life-threatening acute emergencies as long as there's distal circulation. So this is really an acute care style patient. So the most frequently we would be doing assessments on these patients is like Q4. But if they're stable, we may back that off to Q8, Q10, Q12, depending on what's appropriate for that patient. But we're definitely not in this ICU type presentation. Then for the evaluation, so if things are going good for our peripheral I switched the sides. How confusing is that? Let's do AAAs because we always do AAAs first. Sorry about that, guys. Just keeping myself on my toes, I guess. So for AAAs, if things are going good, they maintain their strong peripheral pulses, so they have good distal flow of blood, and their urine output is greater than 30 mils an hour. Bad, uncontrolled hypertension. That's going to either make their aneurysm worse or increase the risk of full rupture, leading to exsanguination on the inside and that kind of bad stuff. So they do have to have very well-controlled blood pressure. That's our goal. That's what we're shooting for and what we want to see in our patients. We do not want to see uncontrolled or very severe hypertension in those patients. For peripheral vascular disease, the good stuff, we don't want them to have that intermittent claudication. They shouldn't have pain in their extremities with ambulation. We want them to have normal blood flow that can handle changes in activity level. If it's not going well, they lose their peripheral pulses. So they have intermittent claudication. For these kinds of things, we need to do our kind of maneuvers to decrease vascular resistance. So bed rest for these patients or periods of being supine so that we're decreasing vascular resistance, trying to improve circulation as much as possible. And we also need to notify the physicians right away anytime we lose peripheral pulses. That extremity is at risk for dying. We should definitely not keep that to ourselves. Fair? Please say yes. Okay. That's it for our vascular stuff. Next, we're going to be talking about heart attacks.